virus, it is clear to me that we should also prepare for a worst-case scenario and widespread infections. Assessing clear information about coronavirus has been a significant challenge for the public to date. The American people have a lot of questions. They want accurate, reliable information about the virus's spread and what the government is actually doing to protect their health and safety. As we have learned from past epidemics and pandemics, outbreaks like this require an aggressive, coordinated, and comprehensive response, as well as timely and trusted, useful guidance from public health officials, as well as security officials. In the coming weeks and months, your agencies will play a critical role in containing the outbreak, educating Americans about this virus, and protecting public health. Whether your response is timely and effective will truly be a matter of life and death. With that in mind, I appreciate you joining us today. My constituents in Michigan and the American people want clear answers to some of the most pressing questions that they have right now. I look forward to hearing what steps your departments are taking to ensure that we have the right plans and that you have adequate resources to actually execute those plans in order to stop the spread of this highly contagious disease. Thank you again for taking time to be with us today.
Thank you, Senator Peters. It is the tradition of this committee to swear in witnesses, so if you'll both stand and raise your right hand. Do you swear that the testimony you will give before this committee will be the truth, the whole truth, and nothing but the truth, so help you God? Please be seated. Our first witness is Mr. Ken Cuccinelli. Mr. Cuccinelli is the senior official performing the duties of the Deputy Secretary at the U.S. Department of Homeland Security. Mr. Cuccinelli most recently served as the acting director of the U.S. Citizenship and Immigration Services. He previously served as the Attorney General of the Commonwealth of Virginia. Mr. Cuccinelli.
Chairman Johnson, Ranking Member Peters, and distinguished members of the committee, it's my honor to appear before you today to testify about the work of DHS and what we're doing to respond to the outbreak of coronavirus disease 19, known officially as COVID-19. Let me first say I'm very proud of the work of the men and women of DHS and our partners in the Department of Health and Human Services and across the government are doing to contain the spread of the disease, slow the spread of the disease, and to prepare for a domestic response. The Department's top priority is the safety and security of the American people, and we're committed to an aggressive, proactive, and preemptive whole-of-government response in fulfilling that mission. As required by Congress in 2018, President Trump signed the first-ever National Biodefense Strategy to build upon our ability to rapidly respond to and limit the impacts of bioincidents like the one we're facing now. We're seeing the strategy pay dividends as we implement a whole-of-government response to this disease. DHS is taking action at airports of entry to support HHS in slowing the spread of the novel coronavirus. DHS is working to decrease the workload of public health officials, expedite the processing of U.S. citizens returning from China, and above all, ensure that resources are focused on the health and safety of the American people. DHS, including Customs Border Protection, Transportation Security Administration, continue to work very closely with our partners at CDC to route all admissible persons who've been in mainland China and Iran in the previous 14 days to one of 11 designated airports of entry where the federal government has focused public health resources. Any admissible person who's been in Hubei province, China, in the previous 14 days is subject to up to 14 days of mandatory quarantine, where CDC has made arrangements with state and local authorities to ensure they're provided proper medical care and health screening. Any admissible person who's been in the rest of mainland China or Iran within the previous 14 days undergoes proactive entry health screening at one of the airports, and if they're asymptomatic, up to 14 days of self-monitoring to ensure they've not contracted the virus and don't pose a health threat. DHS continues to facilitate enhanced health screening of travelers entering the United States who've recently been in China or Iran. Travelers identified by CBP officers during their primary inspection are then referred to CWMD medical screeners. We have 500 of them, over 500 contracted, and about 95 on duty at any given time. And for those that through medical screening are identified as particularly at risk, they are then referred to CDC personnel who are on site and have made arrangements with local health authorities. This has involved over 53,000 air travelers to date. We realize these actions could prolong travel times for some individuals. However, public health and security experts do agree these measures are necessary to contain the spread of the virus and protect the American people. To minimize disruptions, CBP and the air carriers are working to identify qualifying passengers before their scheduled flights. DHS CWMD is currently supporting the enhanced screening efforts through agreements with state, local, or private EMS, public health, and first responder personnel. That's where those 500 contractors come from. CWMD established this capability in response to the Ebola virus threat that was emerging last summer, and these actions ensured a trained, vetted, and badged workforce was ready to rapidly deploy to support CDC with airport screening operations. DHS was able to adapt this capability to quickly address the COVID-19 threat. CWMD is also providing direct support to CDC's effort to collect passenger information at all 11 airports, allowing CDC to provide direct information to public health officials to facilitate contact tracing efforts. CWMD's efforts have significantly increased the accuracy of the data collected. CBP and the U.S. Coast Guard continue their work to recognize, detect, and assist individuals arriving through our land ports and waterways who may be carrying the virus, all in coordination with CDC. The Coast Guard continues to review all advance notices of arrival. This isn't a notice they get 96 hours before any ship comes to an American port. It gives a full accounting of the medical status of everyone on the ship. Captain of the port will communicate any concerns stemming from sick or deceased crew or passengers to their Coast Guard chain of command and the cognizant CDC quarantine station, who will coordinate with local health authorities. To ensure continued facilitation of international trade, non-passenger commercial vessels that have been in China or Iran, or embarked crew members who've been in China or Iran within the previous 14 days with no sick crew members may be permitted to enter U.S. waters and offload their cargo, reload, and depart the port. So that my time is up, I'll go ahead and stop with the opening statement. We submitted it covering a lot of this territory, and I'm happy to answer your questions.
Thank you, Mr. Cuccinelli. Our next witness is Dr. Robert Kadlec. Dr. Kadlec is the Assistant Secretary for Preparedness and Response for the U.S. Department of Health and Human Services. Prior to joining the department in 2017, he served as Staff Director for the U.S. Senate Select Committee on Intelligence and as Special Assistant to President George W. Bush for Biodefense Policy. Dr. Kadlec served in the U.S. Air Force for over 20 years and was named U.S. Air Force Flight Surgeon in the year 1986. In a more expanded biography, I want to read a little bit more. Dr. Kadlec was instrumental in drafting the Pandemic and All Hazard Preparedness Bill, which was signed into law to improve the nation's public health and medical preparedness and response capabilities for emergencies, whether deliberate, accidental, or natural. He served in the White House from 2002 to 2005 as the Director for Biodefense on the Homeland Security Council, where he was responsible for conducting the biodefense end-to-end assessment, which culminated in drafting the National Biodefense Policy for the 21st century. And he served as a special advisor for counter-proliferation policy at the Office of Secretary of Defense, where he assisted DoD efforts to counter chemical, biological, radiological, nuclear threats in the wake of 9/11 and contributed to the FBI investigation of the anthrax letter attacks. I thought it was important to point out just really how extensive your experience is in this, and as a result, what an appropriate witness you are for this particular hearing. So,
well, thank you, Mr. Chairman. I appreciate it very much. That's a very nice way of saying I'm a one-trick pony. Chairman Johnson, Ranking Member Peters, and distinguished members of the committee, thank you for the opportunity to testify before you today on how HHS is supporting the whole of HHS and U.S. government response to the 2019 coronavirus outbreak. This morning, I just want to take a few minutes to discuss how we're addressing this issue from a point of strategic anticipation. Working with my colleagues at CDC, FDA, CMS, and NIH, and across the U.S. government, supporting state and local authorities, we're working hard to contain and mitigate this virus outbreak to save lives and protect Americans. Asper has a four-pronged approach to manage and support domestic response. This includes medical countermeasure development, supporting the healthcare system, incident management, and direct support to state and local entities. In the area of medical countermeasure development, we're rapidly establishing an interdepartmental medical countermeasure task force that includes partners across HHS, Department of Defense, and other federal agencies and the private sector to identify therapeutics, diagnostics, and vaccines that could be rapidly brought through the pipeline to address the coronavirus threat. Specifically, we're looking at point-of-care diagnostic stage, public health, in rapid detection and guide treatment. We're also identifying potential therapeutics to aid and support the treatment of infected persons. Lastly, we're also working very closely with NIH, considering multiple potential vaccine candidates. Combined, all of our efforts are pushing platforms and candidates forward as fast as possible to aid the overall response. Turning, how do we support the public health system through Asper's Hospital Preparedness Program and in coordination with CDC's Public Health Emergency Preparedness Program, or FEP, we've improved coordination and collaboration between hospitals in the public health sector and other entities like emergency medical services. We've also leveraged the National Ebola Treatment Network, which was an idea that was created by Congress and established as a response to the 2014 Ebola outbreak to support the treatment of repatriated persons. As the healthcare systems prepare for possible spread of the coronavirus, this network has and will continue to link technical experts with quarantine and isolation experience to aid transport and treatment efforts at the state and local level. Shifting to our overall response structure, since repatriation efforts began, we've been working with the Federal Emergency Management Agency, Fema, to put in place an active incident management network that is based on the National Response Framework. This is the first time we have formally implemented this structure. Though we have practiced activating this structure during previous exercises, we're doing it for real now. And it means that we can leverage the capacities of FEMA and all the emergency support functions that may be necessary to deploy responders to assist states and local authorities in responding to the coronavirus outbreak, if and when asked. I want to end with just a few brief updates how we're providing direct support to state and local entities. First, I mentioned our repatriation efforts earlier in my statement, where we successfully brought back approximately 1,100 Americans from Wuhan and from the Diamond Princess cruise ship under very difficult circumstances. Currently, there are no additionally planned repatriation efforts at this time, but should the need be raised, we're standing ready to support the State Department or any other authority. We have shifted our efforts to now to provide direct support and aid to states. In the state of Washington, we have used the Strategic National Stockpile to deploy personal protective equipment to protect healthcare workers, and a second shipment is arriving today to augment what we've already sent earlier this week. And we're also planning to send 28 of our Commissioned Corps Public Health Service officers and our NDMS team members to support them as well. We're concerned about healthcare entities like long-term and elder care facilities where we know the most vulnerable populations reside, and are working proactively with CMS, with CDC to provide information on best practices and, when possible, help them shield our elder populations from the impact of the coronavirus. With that, I would like to be happy to yield the rest of my time and be happy to answer any questions you may have. Thank you, sir.
Thank you, Dr. Kadlec. Now, I do want to ask some questions. Normally I yield and ask later, but I just want to get some clarity on a few things because I know this has been confusing. Let's talk about the test kits. My understanding is that 2,500 test kits will be distributed, they say the end of this week, which is like tomorrow. Each test kit can perform 500 tests. So if you do the numbers on that, that's 1.25 million individual tests. Senator Hassan was remarking yesterday that each patient really, to be sure, should be tested twice. That's about 600,000 Americans. Is that an accurate assessment, or where are we at in terms of the test kits? Because it's just so. Who's manufacturing this? Is it a private sector manufacturer?
Well, so there's CDC started initially manufacturing some of these test kits, and within a week or 10 days of when the sequence for the virus was posted by the Chinese, began to work on a polymerase chain reaction test, which is really a genetic test to look for the presence of RNA from this virus. And so they were able to basically do a proof of concept and develop a prototype, and then began to produce that there at CDC, and then have shifted it to a commercial manufacturer called IDT. They're the individuals that basically are making the 2,500 test kits, which include 500 tests per kit, to your point of 1.2 million tests.
And those will be going out to how many different centers?
They'll be going out to 190 places around the country. But quite frankly, the CDC has already distributed 75,000 tests already, of their tests, if you will. And so the intent is by the intent of the Secretary and the Vice President is really to maximize the number of tests that can be performed. Now, to just kind of put some reasonable expectations behind this, these are test kits that are going to be sent out to labs around the country. They're going to have to basically validate these labs for their test procedures and train their personnel. So they won't become immediately available, but they'll become increasingly available over the next week or two to basically test Americans, which is another part of this critical function, which is there have been several things to do to basically enhance our testing posture. One is make more test kits, distribute them, train the people who need to do that, but also ensure that they're validated. But there's also been things that have been done to increase the use of these tests by indicating that people who fit the case definition for possible coronavirus can be relaxed so we can test more people. And that has been will significantly enhance the ability of doctors and first-line primary care physicians and nurses to judge when their patients should get tested if they suspect coronavirus. So there's a lot of things that are in play here, regulatory, definitional, as well as manufacturing and distribution.
So obviously, I think there's oftentimes unrealistic expectations. So it's a new virus. We just found out about this literally 3 months ago. It takes time to first develop the test. It takes time to validate it in the CDC because you don't want false positives.
And with the FDA.
Then it takes time to manufacture the first test kits. Then it takes time in the labs to validate the labs so the personnel, they need to be trained. But you're thinking within a couple of weeks about there will be a capability of testing about 1.25 million tests. And then my guess is that manufacturing can ramp up pretty quick.
Yes, sir. And in fact, I think there's the expectation for this particular company to expand their manufacturing. And there's also a parallel effort that's being done by BARDA to basically engage commercial laboratory testers, the Quest, the LabCorps, to basically introduce the test in their systems. So that would proliferate it across the domain. I think that the thing is, where there's been maybe a lack of test kits, there'll be plenty of opportunity for testing. I think the key thing and what we're focusing on is being able to do point-of-care diagnostics to support physicians on the front line in their offices and to basically test people in their offices to decide whether or not some has coronavirus. What will happen at this point is that it's going to be hospital-based, public health laboratory-based, and then commercial laboratory-based, and we're trying to push it out as fast and far as we can. It'll take us some time, but we're on the way.
And again, as a former manufacturer, I realize this takes time. You know, you wish it wouldn't, but it does take a little bit of time. I think this has actually been proceeding pretty rapidly. So, but everybody recognizes how incredibly important this is because we really can't really get a game plan until we really know the extent of the problem. Let's just quickly talk about the vaccine timing because, again, I want to have people's expectations be reasonable. It sounds like we are developing a vaccine at pretty much a rapid pace. So it will go into phase 1, which is just the safety, make sure the vaccine is safe. When, approximately?
So I think Dr. Fauci is the best in the world in this, and he basically believes it can be done in a couple of months. And even then, after that is done, there'll be a period of time to evaluate the safety data and then enter into the next stage.
Okay, so let's talk about the approximate period of time. So nobody's going to hold you to this,
right,
but
sir.
I want to create the expectation. So a couple months to develop one. Then we're going to have to validate the safety.
Right. Phase 1 study.
And validate that. That'll take
another couple of months.
Okay, so now we're 4 or 5 months out.
Then phase 2.
Is it effective?
Well, that's the phase 2 study that will actually look at that. So I think
that will take how many months?
Another 6 months.
So you're a year before we really have a vaccine that we think is safe and that will be effective. Then you got to manufacture it, right?
And so I think the reasonable expectation is between a year and 18 months, honestly. I think Dr. Fauci has said up to a year and a half, again, to moderate expectations.
And then a year and a half. So let's say everything goes swimmingly well, and after a year we actually have a vaccine that we know is safe and effective, but you're not going to be able to mass produce that yet. But will you be able to produce enough to provide to our first-line responders, to doctors, to nurses? I mean, I would think that would be you would prioritize who's going to have access to this before the general population.
And so that's quite an area that, quite frankly, is I think recognized in the supplemental, the generous funding that you all provided, is that our domestic manufacturing for a vaccine for this particular virus is limited. Typically, and again, a lot of our plans were based on pandemic influenza, where we could use eggs, and much of our capacity, domestic capacity, is egg-based production. And so for these newer technologies like synthetic RNA or recombinant genetic vaccines or cell culture vaccines, we have a limited capacity. So we will be somewhat constrained to get a vaccine for everyone, but to your point, it would be prioritized to those who would need it most, healthcare workers and first responders.
So we already know this vaccine will use one of those more sophisticated techniques as opposed to egg-based.
Yes, sir.
So, I mean, if you're talking about 18 months before you're really starting to manufacture for the general population, we will miss next year's flu season, and you're really not going to have a vaccine available till really the 2022 flu season, correct? That's the right year?
So that's conceivable. And again, that's why we're putting a lot of emphasis on diagnostics and therapeutics to basically look at. I didn't mention in my opening statement, but screening existing FDA-approved drugs that may have activity to basically do that, and the supplemental has helped us basically actualize that. And so we're looking at thousands of compounds that may be available that we could be using, that could be as well as the candidates that Dr. Fauci has talked about, remdesivir and some other drugs, an anti-HIV drug. But quite frankly, right now, the only thing we really have is really kind of 18th century public health, as well as things like N95 respirators.
Okay. So again, the vaccines in the future is a solution. So now you really, again, turn to how do you mitigate this? I mean, and that will be how do you screen? How do you get your arms around exactly where this is? Quarantines, and we'll talk further about other contemplated actions should this thing really spread and become a far more significant outbreak. But my time's up. Senator Peters.
Hey, Mr. Chairman. Well, this information is very important that you're providing, and as I mentioned in my opening comments, it's just so important for us to get this information out to the American people and in a trusted source. One thing I've called for and added information to the Vice President yesterday is that as I've looked and our folks have looked to find out where information is for the public through the federal government, there's good information. CDC has some information, but there's additional information that DHS needs to have. There is no one coordinated place where people can go to find out exactly what the government's doing with all of the agencies, a whole of government kind of approach coming forward. So, my suggestion is we have a .gov website, .gov, that's trusted by everybody, that really talks about not just what the CDC puts out, but what travel restrictions are, what the Homeland Security Department's doing, all of this where people can go to. Because right now people are just actively searching, and I get this back home all the time. They're actively searching for information. There's all sorts of websites that are not accurate. There are folks that are trying to peddle products and create fear in order to make money. I mean, there's a lot of stuff happening right now. We've got to tamp that down. And to me, to have one coordinated site makes sense. Does that make sense to both of you gentlemen, that we have a place where all the agencies, and it's trusted, a .gov site? Mr. Cuccinelli?
It does. Obviously, DHS, we have used our websites for each agency and at the departmental level to describe what we're doing. But this is, as Dr. Kadlec described it, is a whole of government approach. It's a complicated interaction at the government level. I would also note, and we'll talk more about it, I'm sure, the preponderant role that local and state officials play in this response, and then coordinating between different levels of government as well. So, yes, and I saw your letter, Senator, was glad to see it. And I believe that it makes an awful lot of sense, particularly in a circumstance like this, where while Dr. Kadlec, for instance, has the lead federal agency, there's an awful lot of us working on this subject, which is why the President convened the task force and so forth. So it's definitely something we heard you loud and clear in your letter, and we're taking back to the task force to talk about.
I appreciate it. I just say we just saw another incident. I'm looking at the CDC website putting out facts about the disease. I know last night the President was being interviewed, and some of the comments that he made has caused some confusion. So I want to take an opportunity at this hearing. It says here, if you are sick, to keep from spreading respiratory illness, you should stay at home when sick. Is that accurate? You should stay at home when sick? I know there's some confusion now,
Yes,
which
sir.
is why it's important we have one trusted source.
Yes, sir. I
Kadlec?
think that is part of the best thing is self-isolation. If you have a respiratory illness and you're not sure what it is, if it's flu, good reason to stay home. If it's coronavirus, better reason to stay home. but it's a good practice.
Right, great, thank you. Mr. Cuccinelli, there are some reports that some foreign nationals have traveled to China in the past 14 days are actually coming into Canada, which doesn't have those same restrictions, and they're crossing the land port of entry from our northern border. Obviously, Michigan has a very active northern border, but all across the northern border. Are you aware of these reports, and is CBP conducting any screening at the northern border to try to intercept folks who may be using Canada as a port of entry and then using a land port to come to the United States?
Yes, Senator. So to broaden the context even further, it has not been uncommon for Chinese nationals to fly to Tijuana or Vancouver or Montreal. That's not the limit, but by way of example, and then cross into the United States. The three largest land ports of entry for Chinese nationals are Blaine, Washington, Buffalo, New York, and San Ysidro in California. As you know, of course, with Detroit, they're not the only ones.
Right.
And at those three ports, the numbers are sufficiently high that we staged in cooperation with HHS medical personnel there, much like we have at the airport. Wasn't widely advertised necessarily. I would note that the 212F proclamation applies at land as well as airports, and we have excluded over 300 foreign nationals. Some people may find it ironic, but the largest excluded group are Canadians. And it is Canadians who had traveled to China in the previous 2 weeks. The next largest group were Chinese nationals. So, and then it drops substantially from there. I want to say 90 Chinese nationals. So the challenge you pose is real. We have been very aware of it and confronting it head on and turning those folks back, frankly.
So do you screen passengers in vehicles? Because it's a different screening process, clearly, when you're coming across the land border. Easier in an airport as you're walking by CBP
Right.
folks. How do you deal with passengers who are in the vehicle and have an opportunity to really screen them?
So the first screen and the most important screen that CBP is best at is a travel screening. So, for instance, I described turnaways, people who were not allowed in the U.S. because of their travel history. So CBP does have some access to this at the border, depending on how the individual or family, perhaps, in front of them came to be there. If they came through air travel recently, that is a fairly straightforward determination. But they are also doing interviews, essentially, of people at the ports of entry in addition. So if you think of the airport arena, the CBP folks do a travel interview. Where have you been? Who did you encounter, et cetera. Then the next layer, you get more of a medical interview. But that first one, it's the location where they've been that is the first and biggest flag. And predating this virus situation, CBP has always had direct access to CDC when people present in front of them with the appearance of illness. Now, of course, the danger here is you can be asymptomatic with this particular virus, but that process has been vigorously engaged in both borders, north and south.
But you're talking about airports. It is even more complicated when someone's coming across in a vehicle.
Yes, yes.
To address that, you're coming across in a vehicle across we have the two of the three busiest border crossings in North America are in Michigan. Lots of vehicle traffic. How are you doing that?
So the main screen that is our first filter and our biggest filter is the travel screen. So we're using the data systems we have available to our officers and that interview, which, while they were always doing it, there's obviously a heightened focus on China, on Iran, but also Korea, Italy, Japan, et cetera. There is not a proclamation barring those, but if you get a yes answer to those areas of the world, you're still going to pay closer attention, and these are not medically trained individuals, but if there's anything they suspect, then those individuals will be pulled to secondary screening. Contact will be made with CDC, and it essentially becomes a consultation at that point with genuinely medically trained folks, but who are not physically present.
Right. Thank you so much.
Yes, sir.
Bottom line, it's a far from foolproof system. And again, that's just the
this
nature of the beast. I mean, that's go ahead.
Yeah, if I could, that's a really important point, Mr. Chairman. This has never been from day one intended to be a hermetically sealed process. We are trying to reduce and delay the biggest peak in the virus wave hit on the United States of America. And all of these steps reduce and delay, they do not stop the virus. And we've never suggested we were capable of doing that. And viruses don't care about boundaries, right? So it's an obvious point for us to try to provide extra safety to the American people, but it is by no means foolproof.
And again, my comment's not a criticism, it's just trying to create realistic expectations, okay? Because if it was hermetically sealed, we wouldn't have trade at the border. I mean, it would just be, again, overreacting here would be unbelievably costly.
Right. And I just say, the only idea is just to slow it down, to buy time, to have more testing kits out there, to be able to mitigate it. And you're buying us time at the border, so thank you for doing that.
Which is what Dr. Fauci said in our private briefing. The travel ban definitely delayed this, definitely helped mitigate this, reduce the...
And it was contrary to the models. So it was not necessarily predicted to work that way. Our analysis in the task force, we came to a different conclusion, and now we can Monday morning quarterback ourselves. That has clearly been effective. Doesn't mean perfectly, as you point out, Mr. Chairman, but it bought us time. It bought us time.
Senator Carper.
Thanks, Mr. Chairman. Welcome. Thank you for joining us today and for your testimony and for your work. Dr. Kadlec, given the potential for a fairly rapid spread of this virus, we can't afford for patients to delay screening because of concerns of affordability with respect to their insurance deductibles and copays. Recently, the news media has documented one short-term health insurance plan in Florida, I believe, billing a patient more than $3,000 for his coronavirus screening and flu test, $3,000. What are you and your staff doing to ensure that coronavirus screenings and treatment are low cost and affordable? Have you asked health insurers and employers to lower or remove financial barriers to coronavirus screenings?
Well, sir, that was appreciated, and that is why Seema Verma, Dr. Seema Verma, is now a member who's the head of the CMS, is part of the task force, is to really focus in on that part of the problem. One is about the accessibility of health care for people who may have the coronavirus and how that is being covered, as well as the affordability issues. She's been engaging with insurance companies, and it's not surprising that someone may be taking advantage of this, but she's not someone to be fooled with, and I clearly have confidence that she's going to engage on this fully. But we can certainly have her available for a briefing for members if that would be helpful to talk more about what CMS is doing to address that concern, accessibility and affordability. Sir.
Yeah, I think that would be well received. Thank you. There's a bipartisan commission on biodefense. I think, Dr. Kadlec, you might have been the founding staff director for that commission. I think it's co-chaired now by Tom Ridge, former governor, former secretary, and Joe Lieberman, who was once the chairman of this committee, as you may recall. In 2015, that group issued a report. I think that report included 33 recommendations to improve our nation's preparedness for intentional or naturally occurring biological threats. I'm pleased to know that the President has filled one of those recommendations, and that is by centralizing response efforts at the highest level of government, in this case with the Vice President. Many of the recommendations, however, remain unfulfilled. As a founding staff director of that commission, could you just speak for a minute or so about the recommendations that still remain to be completed and what stands in our way for completing them?
Well, thank you, sir. I think just broadly that there was a second one that was completed. That was the National Biodefense Strategy, which was really the foundational document or effort to really understand what as a whole of government we need to do. There was a lot of great work that Congress did with the administration back in 2005 and 6, and quite frankly, that's unfinished business. And I think that was the intent of that study panel, to basically evaluate what needs to be done. So broad strokes, in the healthcare system, we have a healthcare system that's about 95% privatized, that's running on very limited margins in terms of profitability, limited surge, and that surge capacity or lack of surge capacity is going to be tested to the limit here. So that's one area in terms of health or hospital healthcare system preparedness is a major vulnerability. The other one, a critical infrastructure, is the public health infrastructure, which is really about the people at the state and local level. And there are serious issues there in terms of the numbers of people who are willing to get involved in that business. I call it the Rodney Dangerfield of medicine. They get no respect because when they do everything right, nothing happens. And it is a circumstance, I think, there that really does require a little more nuanced effort to promote and incentivize that. The third is a different kind of infrastructure, and that is, well, I'd say the infrastructure for medical countermeasure development. We talked a little bit about the domestic production of vaccines, and that's a good thing because if we can expand that, that's not only making sure we have the right vaccines, but we have great jobs for Americans in many parts of the country and really enhance innovation in healthcare. That's the fourth element, where we're doing some of that to address maybe some issues that would be related to supply chain that have to be addressed, as things like active pharmaceutical ingredients, the precursors for that, and where that's manufactured. Much of it's overseas and a great vulnerability, as we will learn through this experience. So there are four quick things in broad strokes that I would suggest that study panel has done to raise our awareness and focus our efforts to do that.
And you may have answered that. I'm not sure that you have, but just take another minute about talking to us about additional steps that the administration has taken to fill other recommendations. You've mentioned 4 that have been fulfilled, but the other 30-some that maybe have not been.
Yes, sir, and I'll put it in broad strokes because we talked about the biodefense strategy. The one thing was the executive order on pandemic influenza, which really talks about, relevant to this issue, quite frankly, how do we basically manage a potential pandemic, a flu? And again, a lot of that is really about speed of action, which I think is a fundamental issue in this event. The virus is moving faster than sometimes we can even think and act. And then the second thing is really about domestic capacities and supplies, things like the strategic national stockpile that have to be maintained over time. I'll just point out that one of the findings out of the biodefense strategy was we invest about $8 billion in this kind of activity each year. Sounds like a lot of money, but when you consider that an aircraft carrier costs $17 billion and we have 12 of them as a country, that gives you some kind of scale of what we invest in one arm of our national defense that we probably want to invest in our national health security.
All right, thank you. As you know, pharmaceutical companies that exist, maybe that are founded and operate exclusively in this country, oftentimes partner with pharmaceutical companies in other parts of the world in order to try to solve Alzheimer's disease, Parkinson's disease, MS. What kind of collaborations are being encouraged, should be encouraged with respect to shortening the development time for the vaccines to address this virus?
Well, so there are some examples. CEPI is a group that's kind of an international consortium that involves the Wellcome Trust, Gates Foundation, U.S. government's involved, several European governments are involved to focus on major disease areas. Coronavirus is one of them, quite frankly, as well as Marburg virus, a hemorrhagic fever. And I think those kinds of initiatives are valuable because they can, if you will, consolidate small resources and give bigger opportunities. And again, tap into the wealth of innovative thinking around the world to address some of these hardest problems, and also understand that in many of these cases, the underdeveloped world is probably the greatest at risk. And so to make it affordable and more accessible. So those kind of models are very helpful. The Global Health Security Agenda is another thing that was created in the Obama administration, perpetuated in the Trump administration to address how we can build capacity in countries so they can be better positioned to help themselves. That was the success of the Western Congo outbreak of Ebola, where small amounts of money helped build the infrastructure as well as the availability of an effective vaccine. Obviously, Eastern DRC is a different story, but those are some of the examples I would use, sir.
Great. Thank you so much.
Senator Hassan.
Well, thank you, Mr. Chair, and thanks to both of our witnesses, not only for your presence here this morning, but to you and your teams. Thank you for your service and theirs, and please take our thanks back to everybody on the front lines. Dr. Kadlec, I wanted to just start with following up on Senator Johnson's line of questioning about what we can be communicating to our constituents about the timing of increased testing availability. You went through, we've got tests at public health labs. Now we're surging up on the commercial side. We've talked about 1 million plus test capacity, but part of the process here is going to be once the commercial labs get these testing kits, they've got to validate them, right? So how long does the validation process take? So I'm just trying to get to a timeline so people understand when this surge will really be making a difference in their experience.
I think the key thing is based on what's the availability of these tests now and in terms of delivery, they're beginning delivered now.
Right.
That in the public health labs, that'll be increasingly by the end of next week, you'll probably see very high capacity and capability. So about a week, and then you can imagine that the commercial laboratories will be lagging about a week behind them.
And then how long does the validation process take?
It takes several days, a couple of days to do that.
For each kit?
For basically, no, it's the machine and basically validating the test itself on the machine and the people who have to basically work the machines and the test kits.
So I think it would be very helpful, and I want to move on to some other questions. I don't want to belabor this, but if the administration would put down a timeline so that people could see in writing on a website when to, you don't have to promise an exact date, but when it would be reasonable to expect commercial labs to be able to perform this testing if your doctor suggests you get it. I think that would be very helpful. I wanted to move on to another issue. As you know, Dr. Kadlec, the National Disaster Medical System and other programs play a critical role in ensuring that uninsured and underinsured patients can receive care during emergencies by helping reimburse hospitals. I know that you mentioned earlier in the week that this issue was under discussion within the administration. Can you provide an update on those conversations and more broadly, what the administration is doing to help ensure that underinsured and uninsured patients can receive the emergency care that they need?
Well, ma'am, I'm probably not the best one to answer that. I think Dr. Verma may be.
Okay.
But I do know that in the supplemental, there's monies to basically support that would basically expand that. I think it's about $1 billion. So you were very generous in that allocation. And I think that will be money that will be used for that purpose to basically ensure that we can take care of everyone, literally everyone who's afflicted with this.
All right, I will follow up with Dr. Verma to be sure, but it's going to be an important issue, and if we need more resources to make sure that people are not only getting the care they need, but once getting the tests they need so that they will not be infecting other people. Earlier this week, Dr. Kadlec, I met with New Hampshire's public health officials. They have in-state stockpiles of protective equipment such as masks, but they recognize that their stockpiles may be quickly used up, and we've already had at least one confirmed case in New Hampshire. Public health officials in my state have attempted to order more supplies, but they were told such supplies are on back order until May. Based on your testimony earlier this week, I am concerned that the National Strategic Stockpile won't be sufficient to meet the demand. What is the timeline for getting the equipment in the field, and how will you advise people to protect themselves in the interim?
Well, ma'am, we've taken a multi-pronged strategy to basically address what I think is your point, which is unless you have it on hand immediately, you're going to face some challenges. And so one is we have a stockpile, a limited stockpile right now of masks. When I say masks, surgical masks, N95 respirators, and we are in the midst of procuring more immediately, meaning tens of millions, and then have introduced or released as of yesterday a request for proposals for 500 million N95 respirators to basically be provided over the next 6 to 12 months.
Okay.
So the intent is that will ramp up.
And the supplemental provides funding for that,
Yes,
so
ma'am.
that the manufacturers know they'll get paid. Okay,
Yes, ma'am.
so do you have a plan in place to ensure that firefighters, public health officials, and other first responders are appropriately prioritized for receiving the equipment?
And we've met with the manufacturers yesterday, and I think that's one of the conversations we're having. They're making allocations on their own, and I realize that in the course of, let's say, just these N95 masks, in a given year, only 10% is used by the healthcare professionals and lump in the first responders. And so much of it is used by construction, mining, and manufacturers. So the FDA has given an emergency use authorization to allow non-medical masks to be used by a broader population, first responders included, and we're going to try to work to see if we can get an allocation to make sure that those first responders are covered.
Okay, so that is helpful to know. In addition to states needing these supplies, it's going to be important to provide training to any responders or providers who will be tasked with assisting or treating coronavirus patients. What efforts are underway at the federal level to ensure that responders and providers can access training on the use of personal protective equipment?
Well, thank you, ma'am. One of the critical things, and again, a product of Congress's work, has been the National Ebola Treatment Network that was created post the 2014 Ebola event.
Right.
And so with that, there was more generous monies then than now to basically address not only 10 regional centers, 3 national centers of excellence, but we've also, like in the North New England area, started a regional disaster health response network with Mass General Hospital that's working with your catchment area to basically train and prepare people. So that will be one mechanism. We can get training out and specific information on how to manage these coronavirus experts. And actually, we use some of the people from Mass General in the repatriation of the people from Diamond Princess.
Okay, I think it's going to be important. It's something that I asked Acting Secretary Wolf about yesterday, too, because in the proposed DHS budget, there's actually cuts to programs that train first responders in this kind of work. So I want to make sure we're focused on that. I am just about out of time, so I thank you both, and I thank you, Mr. Chair.
Senator Rosen.
Thank you, Mr. Chairman. Thank you for being here. I know you've been in a lot of hearings. We appreciate your round-the-clock work. And as no surprise to anyone, the virus is moving fast. Nevada's just reported its first case of the virus today. I've been in close contact with our state officials, our governor's office, and I want to emphasize, really stress the importance, just like the other senators have here, how important it is to keep those clear lines of communication open with really good data that they can respond. There are boots on the ground. But what I'd like to address is federal assistance for the impacted individuals. If larger quarantine measures are needed and medically justified, what plans are in place to provide relief to those Americans who may miss work due to government-imposed quarantine, but not necessarily to their illness? Many folks live paycheck to paycheck. The loss of a few days' work is a major hardship, let alone staying home for a few weeks. This could lead to people losing their homes, not being able to afford food or other essentials. And so if we have disaster-like situations on the ground, what can FEMA do to help alleviate this in the short term? What do you need from us to help with that?
So FEMA has been in place with Asper at HHS for almost a month now, and assisting them, bringing the expertise FEMA brings to disaster response to this effort, still with Asper as the lead federal agency, of course. People naturally look to Stafford Act, and this is a disaster of sorts, but the response mechanisms are not the same. It is not currently anticipated that you would see a Stafford Act declaration. The intensity of the problem will be different in Nevada than it will be in Virginia, for instance. And so there is the base fund that where governors can make requests when elements of their systems are overwhelmed for funding. There is a $5 million cap that is waivable for that, and this is not the disaster relief fund, the $34 billion disaster. This is a base fund that has about $640 million or so in it.
And would they be able to use this? We know that around the country, some places are reporting school closures. We could anticipate maybe closures of senior centers. So we have many kids across this country, many in my state, kids on free or reduced lunch, free breakfast. We have senior centers where those seniors are reliant on those meals every day. How do we ramp up and give the ability, if there's a school closure, senior center closure, to use Meals on Wheels or give brown bags to these kids and their families? Can you speak to that?
Yeah, I believe, but it's belief. I believe Secretary Azar has some authority to expand aid, welfare programs under these circumstances, but FEMA nor DHS do not have dollars available that are legally that would legally fit the description of the relief you're describing, Senator. So that's something that I believe is being covered and addressed in the supplemental, and that is the appropriate vehicle. And I would just note more generally that Dr. Kadlec referred to the planning efforts that have gone before this all arose, and we operate off the PANCAP 2018 plan. And in that plan, it was envisioned that the financial vehicle to deal with an outbreak of this nature was via supplemental. So we are sticking with that plan, and as was said 6 weeks ago, if we need dollars, we'll come to the Congress. We're here now, of course, and that discussion's going on, and it is including the kind of things you're describing.
So our governors would be able to request this and funnel it to communities that need it, is what you're saying?
No, I think we're mixing two things. If the supplemental includes monies to address the types of shortcomings, financial shortcomings you're describing, then the answer would be yes. There's nothing currently legally in place that FEMA has available that would fulfill the needs you're describing. So I want to make sure that.
So we may have to look to that in the future and see
Yes,
what we
ma'am.
have to do to take care of those vulnerable populations. The next thing I'd like to ask you is about immigrants that are seeking care. You know, Nevada's diversity is its strength, with about 1 in 5 Nevadans born outside the United States, many more living in households with immigrants, some of whom are undocumented. As we work to contain the coronavirus, we have to ensure that there's timely access to medical care for everyone who needs it, regardless of their status. This is a public health and safety issue. Anything less puts all of our communities at risk. So, Mr. Cuccinelli, no one should be afraid to seek care as the coronavirus spreads, placing our communities at risk. Will the department refrain from apprehending individuals based solely on their immigration status while they're in the process of seeking care?
So much like the CDC-CBP relationship pre-exists this virus, it is something that has stood before. ICE also has an already in-place policy, their sensitive locations policy. They do not do enforcement in healthcare facilities absent single case exigent circumstances. So there is no reason anyone should expect that law enforcement
Would they
to
refrain
take
from
place.
potential intimidation factors, such as placing vans outside of community centers or health centers where people may go to seek these tests?
That would be consistent with the policy, Senator.
Thank you. I yield back.
Mr. Cuccinelli, very quickly, because we discussed this, Senator Portman brought this up yesterday. He had a chance to look at the supplemental. $0 for DHS. And we talked a little bit about this in the cloakroom. Can you describe what the, I guess, thinking of Congress is on that, and how DHS is going to get the funding to do the things you need to do in this situation?
So the easiest starting point on that is what is already going on. So FEMA is in the office every day with Dr. Kadlec assisting HHS. That is financed by HHS. So there's interagency agreements in place. So dollars that flow to HHS to address the virus challenge as the source of the lead federal agency do flow to DHS when we're providing those sorts of supportive efforts from any of our agencies or components, the most obvious one day-to-day being FEMA at the moment.
So there's a mechanism in place between agencies, so you're not concerned when you look at that supplemental, well, you know, where is our support, where are our resources? You're going to get those through HHS. And again, administration requested $2.5 billion. We're going to give them $8 billion. Resourcing should not be a problem.
That is exactly how this will work going forward, as it has, as I noted, for the last month or so.
Okay, Senator Hawley.
Thank you, Mr. Chairman. Thanks to both of you for being here. Thanks for the excellent work that you're doing to address this outbreak. And I have to say, it's very concerning. I'm concerned about the spread of the virus nationwide. I'm also concerned about what this has exposed. One of the things is I think the fragility, the vulnerability of our medical supply chains. You referenced this a moment ago, Dr. Kadlec, the fact that for medical devices, Too many of our drugs or pharmaceuticals themselves are manufactured in whole or in part in other places, China in particular, and now we've already seen early reports about potential drug shortages because of Chinese factory closures. This is something that we've got to scramble to address now to make sure that we are not, as this outbreak continues, that we're not caught with severe medical shortages in key drugs, antibiotics, antivirals, but also going forward that we take necessary action. So, Mr. Kadlec, let me just start with you on this. Can you describe the actions that Asper and the task force are taking or have taken to ensure that our healthcare providers have uninterrupted access to personal protective equipment like masks and gloves, rather?
Sir, I think the key thing is we've been working with the manufacturers, the key manufacturers, all the manufacturers in the United States with the distributors. And again, it's kind of a delicate balance to ensure that what is made available is available into the stockpile, and not only our stockpile, but to distributors so they can provide for private healthcare workers as well as institutions. Many states do have a limited supply, a limited stockpile, and our intent is to basically support the states by providing them materials, as we did in the state of Washington, to basically supplement what they already have on hand, what's available commercially, to ensure that they don't run out in an emergency of this nature.
In your written testimony, you wrote about the strategic national stockpile and that it's working hand in hand with commercial supply chain partners to monitor shortages. Can you just elaborate on that?
Sir, basically, again, if not daily, weekly conversations with the major suppliers, let's say overgarments, DuPont, respirators, 3M, Honeywell, all the others, to basically understand what their allocations are to the private sector and what are the needs for the federal government as well. And there are many departments and agencies that have needs as well, and we're monitoring that so that we can moderate what is perceived needs versus actual needs to ensure that we have enough in the pipeline for the private sector to meet their first line needs.
It's my understanding that the FDA is currently working with manufacturers to monitor potential shortfalls for drugs and devices. To what extent are manufacturers complying, to your knowledge, with requests from the FDA in this regard?
Sir, the FDA does this through a confidential kind of business arrangement with them, so I do not have visibility entirely as appropriate in this case to know exactly what the particulars are. But Dr. Hahn would be an excellent source to come in and brief you all on what they're doing. At this point, however, there's only one drug that prescribed drug that has been identified as being potentially at a shortfall. There are alternative products available in the U.S. market that could be substituted. So the impact of that limitation doesn't seem to be great. But he's kind of monitoring that like a hawk with his team to ensure that they can not only identify near-term but longer-term risks to our medical pipeline.
I mean, my own view is that we need to give the FDA more authority to look under the hood, find out exactly where our drugs and medical devices come from, what the supply chain vulnerabilities may be, and then give them the authority to backfill by speeding up approval of alternative devices or drugs manufactured in other areas. And I've introduced legislation to do just that. Mr. Cuccinelli, let me turn to you. Do we need to be considering expanded travel restrictions as the virus spreads, and how do you evaluate that?
Well, the short answer is yes, but it's yes because we've literally been considering them on a daily basis. And the driving factors would include, and they vary how they weigh in each country. First, the transparency of the nation under consideration. You compare, say, China's transparency to Korea. It's a rather dramatic difference. The ability of their own healthcare system to respond to the outbreak in their country, and the capacity remaining after they do so. So, for instance, I'll give you an example. The State Department's warnings early on about China were not just because because of the outbreak. They were also directed to keeping all of our U.S. employees safe, because if you got in a car accident completely unrelated to the coronavirus in Hubei province, there wasn't a doctor to take care of you. So their systems in parts of their country were and are overwhelmed. So that is another consideration. So now China, on the other hand, would be a very different consideration than, say, their neighbor Mongolia, which, you know, you compare the healthcare systems. Mongolia closed their border very fast, and part of the rationale was that they do not have the ability to respond. We're talking in this committee about our strengths and weaknesses and what we could do better in the future, but they have no ability. So those sorts of factors weigh in on those other countries.
And your testimony is that you're reevaluating this on a daily basis.
Daily basis.
Is that an
yes.
interagency process?
It is an interagency process, and we're using two scales to warn Americans. Both the State Department's travel advisory scale, which is a 1 to 4, and the CDC health scale, which is alert to 3. And their numbers naturally are off by 1 as we go up and down, so 4 and 3 are the tops respectively. But we have found, as Steve Began, the Deputy Secretary who sits on the task force, would tell you, I'm sure I don't think have ever seen such responsiveness to their travel advisories. We've never seen such consumption by the American public, much like CDC, I believe, had 500,000 downloads of their business advice, their business guidance in the last 24 to 48 hours. So that is all having a real meaningful effect without mandates, without government mandates. Of course, there's a 212 proclamation with China. The TSA issued security directives yesterday, effective yesterday, with respect to Korea and Italy, but really a very minimal legal impact, more advice and weight of the value and credibility of the government advice.
Very good. Mr. Kadlec, Dr. Kadlec, let me just come back to you before my time completely expires. I'm sure that you're aware of news reports I've seen of that in other countries like South Korea, for instance, is performing over 10,000 diagnostic tests per day, and they've even set up drive-through clinics in South Korea where citizens can go and be tested. Why are we not at scale and able to do something like that? And while we're on this topic, can you explain the precise reason for the defective kits that we saw earlier?
Sir, I can't provide the exact reason for the defective kits. We probably need to have CDC come and brief you on that. But in terms of the scaling, and the earlier conversations by the chairman were that we're scaling up now by commercialization of not only test kits that can be used in public health laboratories, but really engaging the private sector, the commercial labs that can do large volume testing. And so that's going to be kind of rolling off the line here in the next week or two that would significantly expand the opportunity to not only do testing at public health labs, hospitals and clinics, and even doctors' offices that use these commercial laboratories. So that will rapidly be turned around. And again, we may not get to drive-through swabbing, if you want to call it that, but also I just want to comment on that point alone, is you got to do it with some precision how you take those nasopharyngeal swabs. And so the risk is you can swab somebody if you're not careful and get a false negative. So it does take a little bit of training. So I wouldn't think that Jack in the Box will be swabbing here in the United States anytime soon.
Senator Scott.
Dr. Kadlec, we've got a lot of information out at NIH and CDC. No, I haven't seen anything where everyone's talking about the risk for pregnant women. Is there increased risk, or is there any precautions they have to take?
Sir, little data on that, honestly, at this point in time. I think there needs to be a better understanding of that. That is a particularly vulnerable population for a variety of reasons, 2 lives, as well as the different physiological effects of pregnancy on women and the baby, and so that's an issue. The earliest report has been coronavirus report or a case in a newborn in China, but that's the only thing. That's an anecdotal case, but certainly that's a major issue and concern.
So nothing's coming out of South Korea or Japan or
nothing as of yet, sir. We're getting high-level statistical data, but not case reports that are vital for this purpose.
Okay. Thank you. Secretary Cuccinelli, we, from Florida, we have 150 million plus, I guess, passengers through our airports, and then we have all the millions and millions of people go through our cruise ships. What advice are you giving to all of both our airports and our seaports to deal with? We have so many people coming from now all over the world that we know these countries have coronavirus. What advice are you giving them, and what precautions are you putting in place?
So a few things. First of all, the Coast Guard, TSA in particular, have very regular communication with the cruise lines and the airlines. And in fact, I've been doing that as well. You will have noticed that for the first time ever, we were talking about travel advisories with Senator Hawley. We issued a travel advisory, the Department of State specifically, related to cruise ships. not a country, not a location, but to cruise ships, because they have proven to be such a risky venture from a health standpoint. And that was unique. It was effective in terms of the responses. That is not economically good for the cruise ship industry, but we've also seen, I mean, the Diamond Princess was a viral disaster, and avoiding a repeat of that series of mistakes that really are going to take a long time to even understand completely has driven a lot of that response. In the airline front, we are seeing point-to-point declines in traffic. I have data on some of that if you'd like. Needless to say, China's flights have gone through the floor, and Korea has declined, but maybe by half, Japan by about 25%, just by way of example. And there are good reasons for that. The cruise ships themselves, in my discussions with some of their representatives, are themselves trying to avoid bringing on passengers from these hot zones, and to avoid a repeat of the result of essentially quarantining a ship. And as it works in the ports, and you do have many of those in Florida, the captain of the port, the Coast Guard person in command of that port, is in absolute control of that port. And we hold ships offshore when needed, and we have done that throughout this entire time. That has primarily been associated with cargo shipping, because we have tried very hard, to some of the discussion about supply chain, to keep the cargo flowing, not for dollar reasons, but because of the interconnected nature of our supply chains. And we've taken special steps, for instance, keeping ship crews on ships, allowing offloading and reloading of ships, and they leave without the usual coming ashore. In a passenger context, that is much, much more difficult. And we continue to contend with these. You're sitting next to Senator Harris. We're dealing with one coming in San Francisco, and literally as we speak, that is being dealt with directly. And the captain of the port will work directly with the regional CDC head to address these on a case-by-case basis in terms of how to deal with passengers. And as you might imagine, of course, having been governor of Florida, you can appreciate if we were to try to use the healthcare facilities in one port to deal with an entire cruise ship, we would immediately swamp the healthcare system locally. And so that's our counterbalancing challenge, that we rely on CDC to make those state-local arrangements, though they're conversations that the Coast Guard has all the time. So we really are handling them one at a time, but it is with an eye to not bringing ashore virus spread. That is the priority, and it is part of why we've warned Americans not to go on them in the first place.
So take our airports. You know, we all have lots of international flights, and we have a lot in Florida. So what's it going to take for you to do the same thing you did of restricting travel out of China? What you have to have?
Of course, that step was taken in literally the world's epicenter there in the Hubei province, still the largest number of cases in the world. And we don't see anything like that developing to that scale, though Korea and Italy are kicking case numbers up very fast. And it's important to remember, when you take a snapshot of today's cases, that is a week, 2-week, 3-week lagging indicator of what was already there. And so we're operating on this, dealing with this virus that hasn't been known to exist in humans for 3 months yet. Lots of areas we lack knowledge, and so we're trying to err on the side of conservativeness. If you're in the cruise business or airline business, that's hurting you right now, and that's going to keep hurting you for a little while. We don't know how long, but obviously our challenge is to try to keep Americans safe.
So I don't trust any of the information coming out of China. I don't believe they're a transparent country. It's communist China run by a communist party. So do you have any inclination to open up travel from China at any time soon?
That is not on the discussion table. We're not even talking about it right now.
Okay. I think it would clearly be important for my state. But on the cruise industry, do you think you're going to get to the point where you're going to say you're going to start testing everybody that's going to come off?
Again, that would be a case by case. We won't be able to for a few weeks at least. However, we are right now, literally as we speak, flying test kits out to a cruise ship off San Francisco, off California, I should say. It's moving up to San Francisco, with Coast Guard helos and PJs basically dropping onto the ship and bringing kits. And we're going to test, if not everybody, a very large number of individuals relative to the ship. And so that we have full information when the captain of that port in San Francisco is talking to their local CDC authority. And they have already been working as an action group with the cruise line themselves. So this is not popping on us. We've been working it for days.
All right. Thank you. Thanks, both of you.
Thanks, Senator Scott. Just real quick on the cruise industry, I would think in terms of availability of testing kits, because it's such a unique situation, that would be one of the priorities in terms of getting test kits, so that is capable. I mean, that is a capability. Senator Harris.
Thank you, Mr. Chairman. As you know, my state is home to 40 million people, and we have the largest number of cases, 62. Yesterday, our governor declared a state of emergency for the entire state. The coronavirus, I think, presents an interesting convergence between public health concerns and pay equity concerns. Specifically, 2/3 of low-income workers in the United States do not have paid sick leave. And as we know, we have been encouraging people who are sick to stay at home. Often people who are in that pay category also are in the service industry. They work in restaurants, they work in hotels, they work in childcare, they have contact with a lot of people. For them to stay at home in the interest of public safety means they may not be able to put food on their table. So my question is, understanding this is a very real issue. What is the administration planning to do to encourage employers to provide paid sick leave for sick employees so that they will stay at home and not have to face that awful decision about whether they stay at home in the interest of public safety or don't put food on the table of their family?
Second. So I will speak first to the communications we've had with people across the private sector. We, in addition to our accelerated communications with local and state level officials, we have also been talking to non-healthcare private enterprises and encouraging them in this direction as well, recognizing the burden that asking employees to stay home imposes both on the business and on the employee. And you identify, Senator, certain businesses where it's important for everyone else, not just coworkers, for that person to stay home.
Right.
If you're serving food, then the
like
customers of that
worker.
Restaurant don't want you to come to work, right? And
so what can we do to support you talking with the private sector about providing paid family leave during this
so
concern?
CISA has already standing sector consortiums that they're talking to, and this is one of the subjects that they've talked to them about supporting employees who are asked to stay home. Obviously, we're also asking businesses in those lines of work where it's possible to make the telework arrangement so people can keep working and they can keep getting paid. And you don't function as well, but they can still earn money for their families.
But my concern is that for the majority of low-income workers who do not have paid sick leave, they are in the service industry, so teleworking is not an option for them. So perhaps we can follow up to determine how we can support what it sounds like is your effort to figure out ways that we can make sure that these employees don't have to make a decision between paying their rent or contributing to what we know is the
there is more
public
money
health.
available, and I would defer to Dr. Kadlec because that's out of HHS.
Yeah.
Just one other area, ma'am, on the White House Task Force, Secretary Mnuchin, Mr. Kudlow, and the National Economic Council are involved in this, and they're looking at ways, and the conversations I've heard have been about small businesses, and again, a very critical part of supporting individuals and how they could do that. So I'm sure they will welcome the opportunity to work with Congress to figure out how ways to basically support individuals who are facing this problem, who are challenged.
Thank you. Federal employees. So we have many federal employees who, again, their job does not allow them to telecommute. TSA, for example, postal workers. What is the administration's plan for those workers in terms of what is, and then also soon to be enumerators for the 2020 census, which of course starts April 1st. What is the administration's plan for dealing with those federal workers who do not have the ability to telework and do their job?
So one of the subgroups in the task force is dealing with the federal workforce. And of course, to use the Department of Homeland Security as an example, we have the building in Washington State where we unfortunately have had an employee test positive. Right. That is an office building setting. That's one setting that DHS operates. It's a lot different than a Border Patrol station or a TSA desk where a bunch of people are going by you in close proximity each day. For those folks, people like the TSA example you used, Senator, and it would apply to CBP and others, we have made PPP available to them. The medical guidance on how to use it, it does require appropriate training to use correctly in a way that is advantageous to the wearer. And I've been out to Dulles Airport myself when China flights were coming, and I observed the difference in the employees, for instance, the CBP's OFO employees, who when I arrived at the airport with no flights, had their uniform on, otherwise looked like you and me. And when the China flights were arriving, gloves and masks were on.
That's great.
And that is available to all of our employees, and that is true for the frontline folks across the federal government. But that is being closely studied, and we're doing things like pulling down unnecessary travel, other things where we don't create risks for either our employees or the general public.
Thank you. In follow-up to Senator Rosen's question about immigrants and undocumented immigrants, the reality is that we have many undocumented immigrants who are in America's workforce. And we also recently had an announcement from ICE that they were going to increase enforcement. So it is a legitimate and real concern that undocumented immigrants in particular and their family members are in fear of and certainly discouraged from going to public health facilities to receive treatment if they are sick. I heard what you said about the policy. Would you be willing, Mr. Cuccinelli, to issue a public statement that during the crisis that we are now facing around the coronavirus, that there will not be ICE enforcement at these public health facilities, be they hospitals, medical clinics, or things of that nature?
We actually issued a statement yesterday in response to similar inquiries. Obviously, our statement was based off the existing policy, but we did restate that publicly just yesterday.
Okay, that's great. And then for both witnesses, there has been a lot of discrimination against Asian Americans and Asian immigrants. And public health experts agree that the coronavirus does not focus on or target any group by race or ethnicity. Yet we are seeing many, many reports and hearing many reports of intimidation, of profiling, and threats, in particular to our Asian American community and friends. So what is the administration prepared to do in terms of committing to actively dispelling misinformation about this issue? Because it is very real, and we already have enough fear about the public health crisis, but to compound that our friends and relatives and neighbors would have fear about being profiled is something very real.
So obviously we're trying to convey calmly lots of different information about a virus about which much is unknown, and we have woven into remarks really at every level of government the very same concern you've just voiced, because periodically, and we typically do it candidly when we have instances brought to our attention, so that in our now is the Department of Homeland Security, and the same would apply in other places, in our soon thereafter public statements is when we try to knock that back. That's when we talk about that. We want to be very clear, as you said, and I'll say it clearly, the task force, there's without question no difference that this virus shows whether you're black, white, Asian, Hispanic, anything else. And the dangers are to the same people, regardless of race, ethnicity, et cetera. And our responses should be irregardless of people's skin color or ethnicity. And obviously that's how the federal government and how we're responding to it. At the same time, I use the northern border with the China 212F proclamation. More Canadians have been barred from the United States on the northern border than Chinese, 113 to 90 because of that proclamation, and it's because it was travel-based. It wasn't that you're Chinese, it's that you have been in the hot zone in the targeted time period of 14 days, and we'll continue to operate that way and continue to make efforts to knock down storylines or narratives that say anything different from that.
Thank you.
Senator Sinema.
Thank you, Chairman Johnson, and thank you to Ranking Member Peters and our witnesses for participating in today's important hearing. I represent Arizona, a state with confirmed coronavirus cases, and I'd like to acknowledge the Arizona Department of Health Services, the Arizona State Lab, the Maricopa County Department of Public Health, and Arizona State University for their swift actions to care for those individuals and to mitigate potential exposure to those in the community. We need to see that same level of cooperation and coordination on the federal level. I have constituents who were quarantined at Lackland Air Force Base who received little to no information about when they'd be able to go home after another individual who'd been released later tested positive for the coronavirus. While many of them are now on their way home to their loved ones, some are still in quarantine, and this lack of communication is simply unacceptable. Our constituents deserve straight answers from the federal government on both quarantine guidelines and efforts to develop a coronavirus vaccine and treatments. These answers must be driven by evidence-based public health expertise. My first question is actually directed to both of you. Innovative companies, both large and small, are working to develop vaccines, therapeutics, better diagnostics, and are lending their expertise from previous pandemics. Moderna, Johnson & Johnson, GSK, Takeda, Sanofi, Merck, Gilead, Regeneron, Roche, and others are included in this all-hands-on-deck effort. Newer innovators like Arizona's own Phoenix Biometrics have also submitted information to the CDC to evaluate their biosensor technology to detect airborne viruses. But once a vaccine is approved, what will the prioritization strategy be for its deployment, specifically targeting vulnerable populations such as seniors and those with underlying health conditions? And also, what about frontline workers at our Border Patrol stations, our ports of entry, our healthcare workers, and our service members who are stationed abroad in hard-hit countries?
Ma'am, I'll take the first shot at this, and quite frankly, we have actively been reaching out to innovative companies, and we at BARDA and Asper, we actually have met with over 1,500, engaged 1,500 commercial entities, universities, and the like. So we'd be delighted to receive a white paper or any suggestions from your folks on this, and I'll be very happy to provide that information as well. And I think the key thing here is we're looking across the domain. BARDA yesterday put out, my director of BARDA is behind me, if I'm right, still behind me. Basically, they put out a broad area announcement to basically look for innovative ideas across the spectrum of medical countermeasures. So again, there's a way to do it both physically and, if you will, electronically engage in that area. Subject to the issue of the vaccine, clearly that's not an imminent possibility from earlier conversations. 12 months to more like 18 months when we would have something, and the scale of that availability will be dependent on the kind of vaccine that will be developed. And right now there are primarily 3 candidates that are being considered. Moderna is one, Johnson & Johnson or Janssen has another, and then there's Sanofi as well as the third. So much of what will be available will be determined on the prioritization you identify. Clearly, there's a national security component in this, what we would need to protect our forces. There's also the criticality of how do we protect the people on front lines like healthcare workers, and then, as you highlighted, the vulnerable populations, which are significant in our country, but still. And so that's all have to be factored into that. And again, those are, I think, answers yet to be determined, based on, like you said, the best evidence and scientific answers that we can come up in the time that we have.
With respect to the prioritization, you can expect to see, when we reach that point, what I'd call a traditional prioritization, and you mentioned it yourself, Senator, high-risk categories. The mortality rate, if you're over 60 and have a secondary condition, is much higher than if you are under 50. And so limited supply will be funneled to the priority categories that, as typically happens already. We are also going to have to work through exactly the kind of challenges you described, the force protection, as well as frontline law enforcement and first responders, the people who come face to face, and healthcare workers. I'm sure you're familiar with the sort of the first doctor in China to really speak publicly about this has now passed away, and he was an otherwise healthy 34-year-old. But healthcare workers are a limited resource in the sense that nothing any of us are going to do here will make more healthcare workers to fight this battle. So they get priority to care for them because we need them to care for everyone else. And that priority will go forward, and it'll be similar for first responders. So you can fully expect to see that play out. And in your state, as a border state, that will include Border Patrol agents and so forth who man those posts and deal with people who don't come in with documentation, who don't come in with medical histories.
Right.
And we have to be very, very cautious in those circumstances. And frankly, one or two people in a facility like that can wipe that facility out for utility purposes.
Right. Thank you.
Yes, ma'am.
My second question is for Dr. Kadlec. The FDA recently announced it will allow more types of respirators to be used by healthcare personnel as part of the coronavirus response to address shortage concerns. This week, Senator Deb Fischer and I introduced the Healthcare Workforce Protection Act. It addresses manufacturer liability concerns by amending the Public Readiness and Emergency Preparedness Act to include respirators that are certified by the National Institute for Occupational Safety and Health. Could you talk a little bit about some of the coordination efforts that your office is leading to ensure adequate supplies of protective equipment, including efforts to incentivize manufacturers to increase production?
Well, thank you, ma'am, for that question. That's a critical issue that has to be addressed. I happened to be on the HELP committee at the time when the PrEP Act was originally considered and enacted. So I have firsthand experience. And one thing that we didn't consider at that time, quite frankly, is the situation we have here right now, which is then we thought a pandemic of influenza would be the principal threat we would have to confront. And with that, we focused a lot on the idea of medical countermeasures that would be necessary to protect our frontline healthcare workers and vulnerable populations, vaccines, therapeutics like antivirals, and diagnostics and the like. And again, and with that, the PrEP Act was focused on those particular things and did not include respirators. And so that was 15 years ago, a little bit of an oversight, but has significant implications today. And I want to thank you for introducing that bill with Senator Fischer and acknowledge that on the House there's a companion bill with Representative Bacon and Tonko. And I would hope that Congress would make action on it. We did try to make an effort to have it included in the supplemental language, but we're unable to. But this is vital, I think, for the producers of these products who, as you pointed out, the Food and Drug Administration gave an emergency use authorization, which allows non-medical N95 respirators to be used by the healthcare industry. That is vital to do that. We have a requirement that for healthcare workers, depending on how severe this outbreak is, for 1 billion to a couple of billion N95 respirators. And there is no physical way that we can produce those respirators, particularly the medical ones, which are important, particularly in the use in the operating room, intensive care units that are splash resistant. But we can use other ones that are used by industry, which are not splash resistant, that can be used in other healthcare settings that would incredibly expand our ability to protect frontline healthcare workers. Because right now, the only thing we have is that personal protective equipment to protect our frontline healthcare workers and first responders. So thank you.
Thank you. Thank you, Mr. Chairman.
Thanks, Senator Sinema. Senator Hassan has a couple extra questions.
Well, I appreciate this very much, Mr. Chair, and I appreciate our witnesses' stamina, because I know you started at 8 o'clock this morning with all senators briefing. Look, I just wanted to circle back, Mr. Cuccinelli, to something you had talked about on the cruise ship issue. We learned some lessons from the Diamond Princess, right? The first positive test, I think, was February 1st on that ship. It took several days, at least, before a quarantine was implemented. At the end of the day, there were 3,700 people on board. 700 tested positive, 6 deaths. And so we determined, I thought, that it wasn't a good idea if there's a positive result on a cruise ship to keep everybody on that cruise ship together. Now we apparently, from news reports and a little bit of what you said in response to Senator Scott, we're hearing that there is a cruise ship off California, which, to Senator Harris's point, has 40 million people, lots of military bases, lots of hospitals, lots of healthcare and public health facilities, and yet we don't seem to have a protocol to get those folks off the ship into quarantine in a way that would minimize the spread of infection. So I'm just curious and concerned that, given the example of the Diamond Princess and what we thought we learned, that we don't seem to have a protocol in place right now that is clear.
So first of all, let's be clear about what we learned. That was a bad quarantine. That was not a successful quarantine situation, and not just because the virus spread. That was a secondary effect of a bad quarantine. So it's the lessons we learned there were negative lessons. Not, I'm sure that doesn't surprise you.
Well, no, but that's my point, and it is sounding from news reports that what happened on the Diamond Princess is being repeated on this ship off the coast of California.
So the initial assessment with the Diamond Princess before the spread accelerated was that the safest thing for all the passengers was to hunker down.
Right.
It was to isolate in place, and because the quarantine wasn't maintained effectively, that did not hold. Had it been done well, it would have been the right course. And so we don't want to obviously use one bad example to set the rule for everything else, and that's why we've flown test kits out to the ship literally as we're speaking. That's going out so that we have greater clarity on exactly what we're contending with. And we will do, as we did, you may remember the cruise ship that went out of Bayonne, New Jersey, it seems like a long time ago now, but when that one came back, we basically investigated the circumstances on the ship and designed an offload strategy for that ship under those circumstances. And this was the captain of the port working very smoothly with the regional head for CDC there. And then last but not least, brought those who were suspected of infection off the ship separately to prearranged local healthcare facilities. Now, we could do that because it was 4 people. If you start putting zeros on that number with a heavy suspicion they're positive, you can overwhelm local health care capacity.
Understood, and I don't want to belabor the point except to say this. It is not as if we have to take all of the positive people on a cruise ship, people who have tested positive on a cruise ship off and send them to one local healthcare facility. Where the United States, we have lots of them. Some states are being hit a lot more than others. And I just think it's important that we have protocols in place. I understand the importance of factual case-based determinations.
Sure.
But it seems like there's some confusion going on here. So that's just an observation. I appreciate the response, but we have the whole country available to us, and we don't have to worry about overwhelming a single point.
If I just could,
Yep.
we don't. There is a misconception about the capacity we could put together for quarantining. And frankly, Dr. Kadlec is better positioned than I, but this is an important misconception that I think would be helpful.
Well, why
to
don't
this
you address
committee
that,
to
Dr.
address.
Kadlec, because if we don't have the capacity, knowing now for at least a couple of months that highly contagious virus, not as lethal as some, but a highly contagious virus was heading our way in all likelihood, what is our quarantine capacity then, and what do we need to do to increase it? I know that in my state we have the capacity on a state level to quarantine when we need to. So why don't you address that?
Ma'am, we don't have the quarantine or isolation capabilities or even the treatment capabilities to kind of manage these things, even though we've made investments for Ebola, for example.
Right.
It's been really on the single-digit kind of events. Unfortunately, we had that capacity, as modest that is, where we had only a couple of dozen of isolation beds that we could use for Ebola-like disease that we could use here. And we maxed out that capacity, particularly at University of Nebraska, where they have 12 12 beds and they expanded to 16 beds for us to basically help take care of the most seriously at-risk personnel from the Diamond Princess. So I think there's another area for, I think, Congress to consider is how do we do this in the future given the nature of what we experienced, and to the chairman's point, this ain't the last one. There'll be another one behind it.
And how do we ramp up now if we need to is the other thing, because again, we're Americans. We know how to do things, and we do hard things, and we can ramp up capacity. We have a lot of resources, and we have a lot of smart and able people, and we are good people who want to take care of each other. So let's figure this out. One other question, just to follow up on something Senator Harris was touching on. As we know, a lot of people who should stay home if they get sick, to Senator Harris's point, can't stay home and still feed their families and pay the rent. So I wanted Mr. Kadlec just to follow up with you on a question I posed earlier this week in one of our briefings. Sometimes the federal government invokes authorities to help those in need during a natural disaster by, for instance, providing SNAP benefits and temporary assistance for needy families to go beyond those typically eligible. Since we know many of our citizens can't afford to miss a day of work and they face very real financial burdens, have you considered providing similar support during a public health emergency?
Ma'am, HHS and Secretary Azar is exploring all these options, honestly, to ensure those who need care or assistance can receive it. And assuming funding, there are potentially through a supplemental, HHS does have authorities to not only reimburse hospitals, but potentially do these other things. So I think.
So when are we going to have a determination then about whether you're going to do it? Because again, we have a virus spreading in our country. If people know that they could get SNAP benefits or TANF, if they need to stay home, they're more likely right now to self-quarantine when we need them to. So when's the answer going to come?
Ma'am, I'll have to get you a firm answer on that, but I'll take the question back.
Yeah, well, it's a question that's been asked already this week. It's a question that needs an answer. They sent you here to us today, so I'd appreciate it as quickly as possible,
yes,
please. Thank you.
Thank you.
Before I turn it over to Senator Peters, I want to go back to the definition of quarantine capacity. You know, my guess is we're talking about something pretty strictly defined in terms of its capabilities, medical facility, you know, for very sick people, that type of thing. If we have to, I mean, again, if this thing becomes more and more significant, there are things we can do. It may not be perfectly defined quarantine facility, but you can still do things. Can you just define, when you say we have limited capacity, I'm not denying that, but in what way is it limited?
Sir, for institutional quarantine, we have limited capacities, and in fact, DOD was vital and instrumental to basically accommodate individuals and disrupt some of their activities, training and otherwise.
Okay, define, again, you know what institutional quarantine, what does that mean?
It's basically having dorm rooms or places where you can put people. Probably the best place you can quarantine people is in their homes. And in the cases of Wuhan and the Diamond Princess, that was not necessarily feasible when you're basically trying to move a large group of people who are representative across the nation and realize they are at risk and potentially could be at risk to society. You have to put them in one place at one time and monitor them over time. I think if you talk about a distributed approach, the best place to do it, and again, CDC has been working with state and local authorities to do this, is for people who are particularly being identified in travel screenings at airports, is try to get them to maybe their home of record and have them self-quarantine or isolate so that they could be in familiar settings and not put a burden on everyone else.
And again, this discussion all is dependent on this thing ramping up to a certain level of significance where you start doing these things. You know, one of the issues of home quarantine is, will people actually do it? I just read a case of some kid went out to a party, should have been self-quarantined, and here he is out some place where a lot of people are coming in contact with him. So that's, Mr. Cuccinelli, do you have an issue?
Yeah, so in the Ebola experience, what the experts told us is they used this tactic, smaller numbers, but it was over 98% effective. And I just want to give you a sense of scale. I'm sorry the senator left, but you know, if you just look at the number of people who have been referred by the medical screeners at the 11 funneling airports, and that's it, for home quarantining. That's over 32,000 people in only 11 communities. They're all big cities, but they are not unlimited in their healthcare capacity. And the logistics of just getting that person safely, and that means the people getting them to the next point must remain safe, from point A to point B are very substantial. I mean, you just look at the repatriation flights. They were enormously expensive. They were enormous logistical undertakings. And just moving a single person from point A to point B becomes a real challenge. And you get local authorities who say, no, don't move them through here because of the fear factor.
And that's just the beginning of this event. So that would contemplate if you really the only solution might be self-quarantining. I guess there would have to be some kind of penalties, at least threatened. Is that something you already have the authority to do? Is that something the Congress has to pass?
It is really...
Again, this is assuming something becomes far more significant. We're not suggesting.
Yes, but you noted earlier, Mr. Chairman, that we used federal quarantine here in a scale not used in over 50 years. The last time was smallpox in 1969. Remember smallpox? I mean, it's been that long. The real authority and day-to-day expectation is that local and state authorities are going to make these sorts of decisions because they have the most knowledge about their communities. Now, I will say the legal authorities vary rather dramatically from state to state and with home rule states, locality to locality. But that is where we expect those to take place. And I'll give you an example that one of your colleagues has talked to me about. It's at an airport and wonders about the economic exceptions, cargo pilots and so forth going into town. Well, their equivalent of Secretary Azar, the state equivalent, I talked to their attorney general, has the legal authority to keep them in the plane and to force that company effectively to use 2 crews and fly in, turn it around, fly out like we're doing with the Coast Guard with ships frequently. And that is a state authority, and they have the sensitivity to make that decision in the case of their community, because it also has economic impacts, it has all these other impacts that we would rather not impose at the federal level, being Federalist respecters, on local authorities, but we obviously want them to be engaged. We want them to make those well-informed decisions. We stand with them shoulder to shoulder in walking through those. That's why I was talking to an attorney general. That's why we were talking to their health commissioner.
So the federal government's role will be robust in this, but so will the state and local government's role. And we'll certainly be providing resources. We'll be advising. We'll be providing information, accumulating all that information. But in some of these cases, this will really be dependent on local and state authorities to, okay, that's helpful. Senator Peters.
Question regarding the air travel and tracking folks that are traveling. This is both to Mr. Cuccinelli and Dr. Kadlec. Airlines indicate that they don't have all the requisite information that the CDC needs to help trace the spread of viruses. I think it's primarily because passengers only provide a phone number or email when they purchase airline tickets, so it's difficult to track if someone was on that plane and who they're sitting next to and where they've gone. So my question to both of you, are you aware of the holes in the data between what is provided by travelers when they purchase tickets and what the CBP and airlines provide to the CDC? And should we be looking at that?
So, yes, and I think we both have elements to speak to on this. And there's been a 15-year battle going on with the CDC and the airlines, with CDC trying to get a regulation in place to get what they would say are the 5 key pieces of data they need to effectively do contact tracing if the need arises. And the airlines have successfully fought it off for 15 years. The task force dealt with an interim final rule that CDC in fact has issued directing the airlines to provide these pieces of information. There is now a logistical gap between right here as we sit here together and when they can have the systems in place to actually do this, because it has to happen at the point of ticket purchase. And of course, many people will have already bought tickets already. I would also note that airlines aren't the only ones that sell us our tickets. We'll go to Orbitz or Travelocity and so forth, and they provide even less information to the airline than you or I would provide them if we went to their website or called their sales folks. So it's very widely varying. And when this broke out, CBP went through their databases, pulled manifest information going back 2 weeks from the then previously existing Wuhan flights. So we're talking about 7,000 passengers over the course of 2 weeks, roughly. And it took CDC time to process through using that information to try to contact those individuals. And what they found is they could only actually ultimately reach about 25% of them. And when I say they, their partners in this were the local and state public health officials. We mentioned already how important they are. This is one of the roles they play, is the investigation. So what has happened is we evolved, and Senator Johnson and I were talking in the midst of the changes we were making, only as a practical matter, not as a legal matter, where we use that secondary screening. We brought on more contractors and got CDC to give us, meaning the DHS personnel there, their computers, and we started just manually entering this information, one person at a time, straight into their system. Now, since that time, they have been able to contact well over 95% of the people they've been trying to contact. And again, they in this situation is heavily weighted to local and state public health authorities. That's who gets this information. CDC works with them, but they're the ones really with the pulling the oars on this work. So that has changed dramatically, and you can expect, Senator, that when the IFR is functionally in place, not merely legally in place, but the airlines are collecting and delivering this information immediately, we should maintain that level of performance, above 95% contact rates.
Let me quick interject, because I think this is, from my standpoint, one of the prime examples of how responsive the administration has been here. You know, in some of our briefings, I was not getting satisfactory answers out of the CDC. I think you remember that all Senate briefing we talked about that. I'm talking to Ken, and really in a very rapid period of time. Again, you're already on the case. You change that procedure so you can capture that information. So again, that's what I'm saying. From my own personal experience, this administration has been on top of these issues, grappling with gaps, and then trying to correct them as they can as rapidly as they can correct these issues. So anyway, Senator Peters.
Well, as we were talking about the cooperation between industry and government sharing that information, it's also critical we're doing that in the supply chains we've talked about here in the hearing throughout the day, that we've got to have data as to where things are in the chain. So, Dr. Kadlec, information sharing is important, and my question is, are you receiving the information that you need from interagency counterparts, such as data from manufacturers collected by the FDA, to adequately assess supply chain security and where those vulnerabilities are? And if not, what more should we be doing?
Sir, the way we've organized this, and again, since FDA has authorities to have that kind of commercial proprietary information, I look to Dr. Hahn to basically provide me his kind of analysis of what is necessary and not getting into the details. So he is part of our team. FDA is embedded in what we're doing. They have the inside authorities to do that kind of work. And we look to them to provide the guidance as well as awareness as to anything that may be awry or at risk.
So my understanding is the pandemic influenza plan did not formally address drug delivery devices such as needles and syringes, which would be important for vaccines, mass vaccines, for example. What steps is HHS taking to ensure that these types of supplies are available to respond to this outbreak?
Sir, there are a couple of ways. I mean, obviously, you can do it the old-fashioned way and buy it. However, a lot of that material is kind of just in time. So the ability to provide, for example, for a pandemic influenza, you may need 600 million or more, 800 more like 800 million needles and syringes to do that. Now, that's a lot of needles and syringes, right? And so whether or not that can be stockpiled, we've been looking to innovate around that. We've worked with very innovative companies called Paycheck that is looking to be able to just-in-time mass manufacture of a very simplified one-dose, non-reusable needle and syringe. It's quite elegant in its design, and it'd be something that could be used not only here domestically during a pandemic, but be used around the world, particularly in developing countries. So we're looking at that as a joint public-private partnership to address that. And with the benefit of the supplemental monies, we intend to actually kind of work to build some capacity to do that using that kind of innovative approach, as well as other innovative approach like transdermal application or administration of vaccines. Dr. Bright, who leads BARDA here, has been very successful in their endeavors. 53, right? Is that 53? 54. I was here testifying. We probably got 54, so my apologies. But the point is really getting, trying to look at innovation to basically help solve some of these very difficult supply chain issues. We don't just have to do it the old way. We can find new ways to do it just as effectively and likely more cheaper as well.
Right. Thank you. Final question, Mr. Cuccinelli. Is the department now considering issuing an emergency declaration under Stafford Act? Of course, given what happened, we have to wait to see what happens as it develops, so maybe you could walk me through that a little bit. To issue an emergency declaration under the Stafford Act that would allow the government to deploy disaster medical teams, incident management teams, mobile hospitals, or transportation support. We've done that in a variety of times in the past with West Nile virus and Ebola, et cetera. Walk me through that,
So
what you're thinking about it.
The answer to the first part of the question is no, but that does not foreclose the use, for instance, of the IMAT. So just to give you an idea of some of the work we've been doing with the time we bought with the strategies we've been using, you're familiar with our IMAT teams at FEMA, Senator, and they're sizable numbers of people. We have reshuffled them down to 4- and 5-person teams who we provided some additional training to deal with a virus situation versus, say, hurricane, tornado in Tennessee right now we're dealing with right now. And the reason we did that is so because the impact of a virus, unlike a weather event, can be everywhere at once in worst case scenario, we created enough standalone teams that we could help all 50 states in smaller degree with the kind of support that FEMA brings in terms of experience and so forth. So again, not sitting idly, those are the kinds of changes we've been making to our structure so we're responsive to what's out there today. But the Stafford Act doesn't envision a circumstance like this. I mentioned earlier the availability of the base fund, not the disaster relief fund, that really I think you have to go back to the 90s. And it was, I think it was West Nile. It was New York and New Jersey, if memory serves, made requests of the base fund to get ahead of, alleviate. The easier example is a forest fire. Hey, if you help us now, we can keep this thing from getting bigger. Same idea, but it has a $5 million cap. It's a waivable cap. And it is designed to avoid rolling damage to a system. In this circumstance, you're probably looking at when a community or a state has its healthcare system threatened to be overwhelmed because they're getting hit harder than other parts of the country. So there is some money available for that purpose. I would say the Stafford Act is not really designed for this. And not surprising to you, we have analyzed it for these purposes sort of backwards and forwards. So you are seeing, even those IMAT teams would typically be deployed alongside HHS here and in support of them, and HHS would reimburse us. That's how the budget piece would work for their deployment, just as they are for the FEMA team that's supporting them at the SOC right now.
Great. Thank you.
Thanks, Senator Peters. Just real quick, I really need to close this out here pretty quick, but Dr. Kadlec, who's in control of the strategic stockpile? Is it
So I have operational control, and the secretary is really the overall, if you will, I won't say incident manager, but he's the person in charge at HHS to basically manage this event.
So how many items are inventoried in the stockpile?
Sir, it's about $8 billion enterprise. Which
8 or 80?
$8 billion.
$8 billion enterprise. How many items? How many SKUs?
So hundreds of vaccines, therapeutics, all kinds of supplies, masks.
So who and how are the inventory levels set?
So we have requirements that are set that are based on a requirements process. Some of it's been fixated on the basis of what can we buy or what can we afford to buy as much as what we may need, particularly.
So how close are we to actually having the required levels in inventory now?
Sir, I'd have to give you a detailed kind of answer back on that, but I think the thing is, it is something we have a multi-year budget that looks at what we would need to do it. So I think you can look back over the last 5 years as what should be those levels of funding that reflect many of those requirements.
So again, the point wasn't to get the answer to my questions, but to just raise the issue. From my standpoint, in terms of the supply chain and what we need in the stockpile, we have the short-term situation about what we need now and how are we going to procure it, so that if this thing continues to get worse and worse, we've got the supplies. And recognize, again, not to create unrealistic expectations, it takes time to manufacture things. And if it's not in stockpile right now, those are going to be some issues. But again, really appreciate your pointing out that our first strategic stockpile is the number of doctors and nurses and healthcare professionals, and that's a finite amount. And so we need to protect them first. But then long term, I told Senator Hawley on his way out, we do need to take a look at how we fill that stockpile. Do we, based on our experience of how this all ends up, what inventory levels should be there, what things should be inventoried, how much money should we spend? Again, I think somebody pointed out the aircraft carrier. This is $8 billion versus $17 billion. Hopefully we learn from this, and I certainly want to use this committee, and I'd imagine you're the person to deal with in terms of what we need to pass legislatively to make sure that we are better prepared next time. Yes, learn the lessons from this episode and be better prepared. And I will also say, to me, it's ridiculous. I'm a manufacturer, okay? I'm all for global supply chains, but when we have an FDA approving drugs for use in America, the fact that we've really put ourselves in a position where I think it's about 70-some% of the API comes from India, correct?
Yes, sir. A lot of it comes from overseas.
A lot of stuff comes from China, but I mean, that's not a labor-intensive manufacturing process, I wouldn't believe. So there's no reason, I don't believe, that the FDA, okay, it's an approved drug here, it needs to be manufactured here. We do need to take a look at these things and be smart about this. It's the way you do it in industry, we need to do the same thing from a standpoint of government as well. So really want to work with you when the dust settles on this, when we get by this event, we've got to prepare better, and I think that's going to require legislation and appropriation, but it's going to require thoughtful analysis. And so to close this out, I want to thank all the committee members. They're not here, but hopefully they'll hear it, for their respectful questions, for their attendance. And I want to thank you. I hope the press, I hope the American people are listening to the thoughtful responses. It would give them a fair amount of confidence. This is uncertain. We don't know where this is going to go. But from my standpoint, having dealt directly with members of the administration and people throughout these agencies, first of all, thank the men and women of your agencies. But this is being carefully considered. We are thoughtfully working our way through this process in a very uncertain situation. So again, thank you, thank the men and women of your agencies. Again, I really do appreciate the members of this committee being very respectful and thoughtful in their questions as well. The hearing record will remain open for 15 days until March 20th at 5 p.m. for the submission of statements and questions for the record. This hearing is adjourned.